Okay, well, thank you all for joining us today. My name is Maggie, and I'm the Development Director and Communications Director for the EHE Foundation. And before we get started, I'll just share a few housekeeping items. As I stated when you were coming in, we'd love to see your faces. And if you don't mind, please keep your audio muted unless you're participating in the discussion. And you're welcome to use the chat throughout the presentation today. Feel free to use it to communicate with other participants, and you can put questions in there if you need to. We'll try to monitor those, but I think this is going to be a pretty open discussion, so I know Dr. Vesel is perfectly happy to field questions during discussion as well. We want to remind all participants that the EHE Foundation does not provide medical advice. The information provided here is for your information, and we encourage you to contact your own healthcare provider with any specific questions about your health. Okay, so let's get started. With us today is Dr. Tamara Vesel, Chief of Palliative Care at Tufts Medical Center in Boston, Massachusetts, and her research assistant, MD, MPH candidate, Abigail Lebowitz. Dr. Vesel and Abby are no strangers to our community. They led us through multiple sessions about cancer identity last year, so maybe some of you attended those. So welcome, everyone. I'm going to go ahead and turn it over to Dr. Vesel to get us started.
Dr. Vesel, you're on mute.
You're on mute.
Helps to unmute for sure. If I am reacting a little slowly, it's because I'm jet lagged. I came back yesterday from Japan from my vacation. So my apology that I need more help with technical assistance. Thanks, Abby. What we were hoping to do when we contacted EHE, Abby and myself, a few months ago is to think about how to give the community some tools, very practical tools about pain, self-management of pain in cancer. And I'm not implying that all of you have pain, but in our life experience, everybody experiences some kind of a pain. And I truly believe that from childhood to adulthood and old age, being able to manage our pain, recognize it, notice it, and do something about it, and help the medical community to assist us with pain is important. And I think that throughout the life, we can have negative and positive experiences about pain, and it's worthwhile to have a conversation about it. I hope you agree with that. So welcome, everybody. And what we are hoping to do is to actually concentrate on what a person who is in pain can do. Before we start with some of where we are going today, since we have, about 55 minutes, is I will ask Abby, since you have done all the classes, you are into the graduation in a few days, to lead us very simply through our understanding or Western understanding of pain.
Yeah, definitely.
Yeah.
I'll definitely do that. And I just wanted to say it's so nice to see some familiar faces from the previous sessions and also some new faces as well. So I'm really excited to kind of dive into some of these topics. And I think it was appropriate for me to start off, given that I'm also a learner and probably know a lot less about pain than many of the people on the screen today. So I'm excited to hear about kind of different people's experiences. But I think what we wanted to do first was to walk through very basically how, from a medical standpoint, we think about pain, starting from an insult. So someone experiences pain and it can be a lot of different types of way, but we typically think about it somewhere peripherally on the body. And then that pain is transmitted and processed by the body. So different parts of our body, depending on where it is, have different receptors that experience pain differently. Those receptors are stimulated by the pain and then transmit signals throughout the body, going through the spinal cord and then up into the brain. And I think there's a lot of medical terms that for these receptors and the different types of pains and different things, but I think at a basic level, that is kind of how the framework that we think for people experiencing pain. And it kind of happens on different levels as well. And when I was talking to Dr. Vesel about this, we were talking about how when we're thinking about pain, there's also a lot of different ways in which pain can be managed. Whether it's when you're thinking about these different pathways, whether it's removing the original pain origin, or if it's interfering with the pathway that pain is traveling, or using medications to alleviate some of the signals that the pain is sending. However, a lot of these interventions are more dependent on someone else, whether it be someone who needs to physically remove the pain, whether it's a tumor or something else, someone who needs to perform chemotherapy, or someone to prescribe medications, whether it be over the counter or something more intense. So I think today we wanted to talk about things which, as a patient, you can have more onus of, to really kind of not be as dependent on someone else, but maybe work with someone else to really think about your pain. And I think, Dr. Vesel, I'll let you elaborate and kind of dive into more of that conversation as well.
Thank you, Abby, for taking us into this. So essentially, when the information about the pain, whether it's, as Abby said, an insult like a cut or a visceral pain or neuropathic pain, whatever the signal comes through the spinal cord or the nerve spinal cord up to the brain, eventually the pain is processed in the top of our brain, right? In what we call the upper brain. And that's when things become complicated, right? Because pain, from a developmental point of view, the way how the animal and human species have developed is actually sign of a threat to our life. So the pain actually is a signal that something bad is happening. Am I correct? So let's just say that cavemen was setting up the fire and left the hand on, didn't realize that the stone is hot after the fire started, put the hand on. The pain of the burn is telling the caveman to take the hand off so he doesn't get a permanent injury. So it was always a developmentally sign of a danger. The problem with that is what happens when a person has a pain that has, instead of an acuteness, a chronicity, meaning when the pain becomes part of our life, right, with chronic conditions. And that's how conceptually I think about some of our patients with EHE who have chronic pain, right? Not all of you do. Not all of your spouses or children or loved one who you support about EHE have the pain, but EHE patients do experience pain at different phase of their illness. So when the pain becomes a chronic condition, we need to really think about this, differentiate whether this is a threat to our life or threat to our personhood, or it's not as much a threat as a condition you need to live with. And I think this is where in Western medicine, we are lacking a lot of tools, or perhaps we are so much better with the acute management, with the chronic management of pain, that we leave the patients somewhat on their own terms. Does that make sense? All right. Well, so let's concentrate on the upper brain. So upper brain. Oh, I love that. What's that? A dog or a cat? Denise?
That's my cat.
Oh, it's a big one and
Yeah,
so much loved. Oh
he
my
was just
goodness.
sitting here crying for attention.
So, Denise, this is the perfect transition to what upper brain does, right? As much as we think that upper brain is very complicated, from a pain, oh, there is another one who is asking for attention. Connie, thank you for sharing. So what the brain does is it actually doesn't know how to multitask a lot, right? You know, we think we are multitasking in life. In fact, we are always competing for an attention on one main task that we are doing. So when somebody is in pain, despite that the pain is coming from this periphery, as Abby was describing all the time, let's just say there's a tumor that's pressing on a nerve and it's causing pain, you don't experience the pain 24/7. And why is that? Because pain needs to be processed emotionally, right? So going back to Denise and Connie, one of the most frequent way we manage our own pain is distraction. We distract ourselves. So what Denise is doing, I don't know, Denise, whether you experience pain or not at the moment, but let's just pretend you do. The way how you're holding your cat and you are petting your cat, you are distracting your brain from that negative perception of the pain. Let's just pretend. I don't want you to have pain per se. And the same with Connie, right? Like scratching the dog, you know, having this kind of a loving experience, attention to the dog is distracting you from a current experience of discomfort or whatever you are experiencing, or maybe tension, or maybe anxiety. What is Dr. Vesel is talking about? Does she even know what she's talking about? I am the one who is experiencing that emotion, right? So we teach our children from early experience of pain to actually manage the pain, distracting them. Mom picking up the child, kissing the child on the forehead, kissing the boo-boo. We distract that child from that experience. This is our most common way of managing pain in the childhood. And it actually continues to be our main resource for managing pain. The problem with distracting from pain when it's there 24/7 is that it requires enormous amount of effort, right? And it takes away the attention to other important tasks, like raising a child or working or shopping or cooking or other stuff. So we need some other tools. So is this concept clear or that does resonate with anybody? Yes, Connie, that was a thumb up, I thought. Yes. Anybody else is using distraction in pain management? Yes, I see nodding, Denise. Anybody can give us another way how you are distracting yourself from pain? So pets are perfect example. Anybody else?
Dr.
TV.
Vesel, I have a question.
Yes, yes, Abby. I see TV from Joni. Abby.
Have you noticed in your practice with distraction, sometimes if it's a conscious decision to distract, does that change the experience of if it's something that's subconscious where you're just reaching for the dog without realizing that that's necessarily subtracting?
Yeah, that's a good question. I think that, Abby, we were taught to use distraction. So I think on some level it's a subconscious effort. But in fact, when it becomes conscious, and when it becomes conscious on multiple levels, and I will explain what I'm trying to explain, that becomes actually much more effective. So from a simple distraction, scientists or psychologists mainly, or some other, nature and exercise. Yes, Denise, thank you. We actually learned, and we actually learn it from children more than from adults, is that guided imagery, which is a level top up from the distraction, is actually much more effective. And what guided imagery is? Guided imagery, again, is involving the upper brain, but involving all 5 senses. Meaning, when you distract in a way that you imagine an experience, let's just say walking on the beach, and you start to involve or engage, walking in your mind's eye, right? In your mind's image, walking on the beach. I'm walking on the beach, let's just say. Abby, what is your favorite beach? Do you have one? Uh-oh.
I don't know. What's somewhere close by?
Marblehead, right?
Yeah.
That's
Crane
my
Beach,
favorite.
right?
Yeah, or you know, some of the Cape Cod beaches. So you imagine it visually. So I imagine Abby climbing on the rocks. We just did a trip to Arizona, and she was standing on the rock, almost. I was worried that she will fall off. So I imagine me being on that rock. That's a visual image. But if I include another sense, I smell that air on the beach, how it's infused with the salt of the water, with perhaps the flowers on the beach, etc., etc. I'm including now an image, the smell, so another sense. And then I even taste that little sand with the salt in it. And I start to imagine the birds, the sound of the ocean coming in and out. And I physically feel the coolness of the air and the sunshine on the top of my head. You see what is happening. It's become this multidimensional experience. And we hijack that brain, upper brain, from feeling the pain or processing the pain. We take it away for a period of time. Now, that may work for a period of time. Again, it's not a total solution to the pain, but it gives you that release, parasympathetic release, and it gives us that way of getting from that hyper catastrophic experience that pain can give us. Does that resonate with any of you? Have you done anything like that? Yes, Connie, you have that experience. Would you be willing to share that? If you are willing to
Connie, you're on
unmute
mute.
yourself on the left-hand side of audio. Thank you.
There we go.
Yes, Connie, anything you would be willing to share?
It resonates with me a lot because 50 years ago, I started teaching natural childbirth. And I have used those techniques that you are describing, and I've taught them for childbirth, and they have served me well for everywhere from the dentist chair to the recovery room. The whole mental imagery, the whole thought of engaging your senses. It works very well until you get to the transition stage of labor, or when the pain is just really, really, really strong, or really overwhelming. And then I found that the mental imagery trick for me had to be simplified. Like I had to think about time passing, and I had to think about colors. I would visualize counting down from 20, and was like the Sesame Street when they talked about numbers. I would see the number being very large and then whooshing away, and each number would be a different color. So I had to engage in the countdown, and counting has always been a comfort for me. And I had to engage in changing the color with each one. And I also had in my mind that when I got through those 20 seconds, 20 more seconds would be gone, and I'd be closer to the pain medication working or whatever procedure was happening. But my most recent, every MRI and every mental imagery always works for that for me. But I was going in for a surgery, and they were trying to place an epidural, and it is a teaching hospital. So there were like 12 people behind me talking about where to stick that needle. And I was like, I'm okay, I'm fine, I'm going ice fishing. And in my brain, I went ice fishing while they poked around. And every once in a while, I had to come back and say encouraging words to them and help them through it. But mental imagery, I think, is one of the strongest tools I've used for myself, and I've definitely used it for others in my family who have gone through different surgeries and painful experiences. I'm very pleased to hear you bring that up.
Connie, thank you so much for so eloquently to talk about your life journey, 50 years journey of using your brain for pain management, right? And what you are describing is modification of and individualizing it, right? Like somebody at some point taught you something, and then it became your personal experience, which actually is very important. And that personal experience is modified now based on your needs in your current level of need, whether it's going through an annoying MRI with, a narrow space and, potentially not feeling comfortable in that position, to actually helping nervous trainees to do a procedure on you. You were the one who were comforting them instead of the other way around. So that's absolutely remarkable. That works for you. And I love what you are saying. It's not a total solution, but it's a bridge to something. It's yet another tool that you can use, that you actually rely on yourself instead of relying on somebody else giving it to you or making it happen, right?
Right.
So we talked about distraction, we talked about guided imagery and involving as many senses as possible to make this a multidimensional experience, to kind of hijack that mind of not really processing the pain, but instead of processing the image, that's a pleasant, positive, good image, or a very focused concentration. What Connie was talking about when she was talking about the numbers was actually a total focus concentration on numbers shrinking and numbers going from high number to low number. So it was a total focused attention. So what actually Connie, without naming it, is using now is actually stepping from guided imagery to self-hypnosis. And self-hypnosis is actually a way of the patients using the brain, conscious and subconscious brain, to find a solution for that pain experience. And Connie, what you described was finding your solution. Your solution is to find your way of taking that time. You are actually extending and shrinking the time of your pain based on what you need, using the numbers. Clever, absolutely clever. Now, self-hypnosis is very important. We use the words hypnosis and look at it more from the movies, like, oh, somebody makes you do something that you don't want to do. That's not what self-hypnosis is. Self-hypnosis is using your brain in a very focused way to find a solution for your pain. And I don't know whether, Heidi, can you show yourself for a minute? Do you have a video part? Maybe not.
Hold on, I'm going to try to figure it out.
Thanks, Heidi. The reason I am pointing at Heidi, may I share just a sentence about our relationship?
Oh, yeah, definitely.
So Heidi approached me some months ago with and she actually wanted, she lives in Massachusetts as well, and she was, after she found some of the recording on EHE, she wanted to work with me on some of her pain, chronic pain. Is that fair, Heidi? I share that?
Yeah, definitely.
And we started this journey that we are doing today, one-on-one. And Heidi, I was teaching you recently. Thank you. Oh, that's so nice to see you. My goodness. I was guiding Heidi to find actually to become a scientist, but what we were working on was actually one of the ways in training of somebody with self-hypnosis is one of the techniques for managing pain. And Heidi is experiencing chronic pain that has been poorly understood by your clinicians. Am I correct?
Yeah, definitely.
And so she was looking for different ways and has done a beautiful job of finding a way she can manage it, right, Heidi? And training in some of the mindfulness and self-hypnosis is just a piece of your journey in your chronic management of your pain.
Yeah.
So Heidi, we were maybe you can explain this one self-hypnosis tool which we call pain switch. Would you be willing to explain what you are exploring now?
For me, the way that I think about it is finding something in your mind that, kind of feels right to you, whether it be like a switch or a button or, something that works for you. And then being able to kind of get into this like deep sort of meditation type of state and being able to control that switch and dial down your pain. When I was working with Dr. Vesel on exploring that in her office, sorry, I found a button. That's just kind of what popped into my head, and it was either on or off. And so I try to just shut it off. But I'm sure it's, it's different for everybody.
Thank you, Heidi. So Heidi is a high achiever, obviously, because switch on and off, that's a very hard to achieve, right? Like it's really hard to push the button and stop the pain. So Heidi, you are amazing that you are working on that. For the rest of us, it's actually worthwhile to contemplate whether it's in the state of meditation or relaxation, or how Connie is thinking about things like counting, where you, in a relaxed state, start to kind of visualize what the doctors or nurses are asking when they ask you about the level of pain, right? We have these questions about how much pain you are in on a scale 0 to 10. Did anybody ever ask you that? Right? Pretty annoying question at some point, right? Like really annoying. Like, and so what? If I tell you 10, what you are going to do with it, especially if you are in a chronic state of pain, people just kind of, 10, okay, 10, right? But there is actually a self-help in that, because what the doctor or a nurse is asking you is to assess your level of pain, that if they would push you further, would be where that pain number is coming from. Is it coming from the top of your finger where it hurts, or is it coming from a pain center, whether it's an imaginary pain center or it's truly your pain center? It doesn't matter, because it's your pain center. So my pain center may look very different to me than it looks to you. And we may not have as much time right now to explore it, but just imagine that it is, for Heidi, it's a switch, on and off button. For somebody, it can be a thermostat like I have in my room that goes from this to this, or it can be different. I worked with children a lot. They have this most clever understanding of their pain switch. The main reason to work on, if you have a chronic pain, on a pain center or pain switch or pain something, is to actually realize that in a chronic pain, that manager of the pain, that meter, whatever that looks like to you or is relevant to you, gets stuck often. It gets glued on some number. I don't know whether anybody experienced that. Like it just stays there at number 9 or 5, And no matter what we do for it, it stays there. That's very typical for a chronic pain that's not well managed. To learn to imagine the pain, switch pain center, whatever that is in your brain, and start to figure it out in your mind's eye, how to move it around. And it doesn't necessarily always mean to put it down. Even if you can put it up a notch, from 5 to 5.5, or from 5 to 4.5, kind of starting to make it more agile again, because it becomes rigid in chronic pain, is liberating experience for most of the patients. Is that a concept that you think we can work on? Anybody?
That's a new concept for me. I had never really, I didn't know that chronic pain equated with something kind of getting stuck in your brain. So that just knowing that is liberating, you know, kind of like recognizing that my brain may have control over something that I initially thought it didn't have any control over. So that in and of itself feels liberating. You know, not having had the experience where I've been able to control it and dial it down. I can't speak to that, but
Thank you.
Just knowing that is helpful, honestly.
Maggie, that's actually what the main goal of this session is. What you just defined and we were hiding the last 35 minutes is the idea of that, in fact, we have a lot of control over our experience in our body. We do, but in a chronic illness, we lose the control, we become passive. We become like, oh, this is what we are, right? And regaining that control, even for a moment, even for, you know, I'll get my pain down because, you know, in Heidi always talks to me about, I need to get up from bed and get my kid to school. I am responsible for my boy, right, Heidi? So for her, she cannot linger in bed in pain. She needs to find a tool, and it's not always a pain medication because it's not always appropriate, to get up there and get going and get the child to school in the morning, right? And that is gaining control over your brain, in your brain, because the truth is the brain is processing the pain. So thank you for pointing it out. Now, the imagining that switch is actually a advanced technique, but I wanted to point it out. And I wanted us, all of us, be curious about how much more we can actually learn from our brain and how much more we can use our brain for the management of the pain. Oh, fair enough? So if any of you, any of us experience pain, I would just humor you. Just be a child, be curious. And maybe tonight, before you fall asleep, when you are in a state of relaxation, just take a few minutes of curiosity and do an MRI of your brain and find that switch, you know, or look for it and see what will happen. So be curious about it, be playful, be a child. You know, being a child is fun, right? Children are not so worried. Well, that's why Abby is going to pediatrics. Children can manage so many things. They are actually much more resilient than we adults are. So become a child and become curious, like, can I be my own scientific explorer in my brain? Can I gain control of it? So these are three concepts that we went through. Was distraction of the pain in our upper brain, which was, you defined it as walking in the nature, watching the TV, hugging the cat, etc., etc. Then we talked about guided imagery that Connie described as managing her painful experience in her life, whether it's childbirth dental office, currently MRI, or even a spinal tap or an epidural that you had to go through. And now we advanced to more advanced techniques of finding a solution to the pain, managing your pain, which Heidi described as one of the techniques I have been teaching her recently, which is a pain switch. All right. Any questions before we move to another concept? Don't be shy. Any thoughts, reflections? Am I off? Am I totally like talking from a different planet, or it's something that's relevant to you?
What do you tell your patients when they're not able to find the switch in their brain?
That's not uncommon. And that's not a failure of anybody. That's a good question, Abby. It takes some insight. It takes some time to start to learn, relearn, and trusting yourself, right? And that's some of the work that that we have been exploring with patients with chronic pain. I see a little comment. Let me see. Oh, Heidi is saying, I'm current patient of Dr. Vesel. Sorry, I need to keep my camera off. My son's birthday party this afternoon, so I have a lot of going on in the background. No worries, Heidi. Thank you for sharing that. And then I want to go down to, seems to be only a short time solution. Joni, yes, maybe, and maybe not. So it starts as a short time solution, but it actually becomes a part of the toolbox that the patients with chronic pain have. And it becomes a more and more important toolbox. Let me just explain that, Joni. If you want to tell me or tell us more, if you are ready, or text us, that would be great. What you are thinking about short-term solution. I see another comment, very relevant. Our minds are so powerful. So when we published the paper on the patients who I was working with EHE, and we published on a particular one medication, Toridol. That's when Denise and Maggie started to approach me about, working a little bit with EHE. That particular patient was using multiple tools, and the guided imagery and self-hypnosis was becoming very powerful tool. It wasn't the only tool. I'm not pretending that that's the only tool we are using in pain management, but it's very empowering tool to learn about yourself and how you react to pain, and what are your thought processes about the pain, and what other tools you have been using in your life and maybe underutilizing during your chronic illness, because it becomes so threatening that you forgot the tools that you have been using, like Connie. It's not unusual that when you are in pain, you actually need to be reminded about the tools you have been using. Heidi, you are writing something. I can share a great example of why a short-term solution can be very helpful if you would like. I would love that, Heidi. Maybe at the moment I need your help. So would you mind?
Sure. So for me, and I think I've shared this with you during one of our appointments, but there was one night where my pain comes on more at night, and I think it's because I'm so distracted during the day that I'm not noticing it as much. So, I was in bed and I was struggling that night to fall asleep because of pain. I finally fell asleep. I woke up during the night and I was just in so much pain. I really needed a painkiller. Like I really needed one of my pain meds, but I was in so much pain and I was just so tired and frustrated that I couldn't even get myself to get out of bed to go get that pain medicine. So that's when I laid there, and, you know, this was, you know, pretty early on in my appointments and learning these skills. But once I was able to actually think about, oh, okay, this is something I've learned, I was able to like try to get into that like meditative hypnotic state and start focusing there, and calm myself down enough that I just fell back asleep. So yeah, it can be short term, but even those short term bursts can be super helpful, especially in situations like when we're in too much pain to even move to do anything about the pain. So that's my example.
No, that's you know, very eloquent way of explaining what I was trying to explain, that sometimes short-term solutions are extremely beneficial because get you out from this frenzy, and then you have some other tools that
Yep.
you can use. Absolutely, that's absolutely a perfect example, Heidi. Thank you for sharing that.
You're welcome.
Anything else that comes up before we move forward? Yes,
Something that comes up for
Maggie?
me is this idea of distracting ourselves from the pain, but pain is also very distracting. So for example, when I'm in pain, it's hard to focus on work. It's hard to focus on complex mental tasks.
Yeah.
So that's what's coming up for me is just distracting from the pain. It has to be something that isn't super difficult to do. Petting animals, doing the imagery and things like that. I can't personally, or I struggle to distract from pain using something like work, or just something that's, talking on the phone, even, that's hard for me when I'm under pain, because it's all my brain is thinking about.
Absolutely. Absolutely. And I think that is why it's very urgent for patient with pain to have the pain managed with multiple modalities. This is what we are describing today, is one of the few modalities that is underutilized and forgotten, or it's not given enough attention or enough time. And I think part of that is because we don't have enough mental health professionals, right? We don't have enough psychologists who are trained to use this. And physicians are so busy writing scripts of medications instead of looking at all kind of tools. That's why you are absolutely right, Maggie. I want to share another example, another way of looking at pain, because you mentioned something that is very
Dr.
relevant.
Vesel,
Yes.
before you go in, there was just one more comment in the chat from Doug. He said, do you include controlled breathing as part of the mental imagery?
Doug, this is a great question. I think that controlled breathing, or breathing per se, is actually dovetailing with where I was going. I think actually breathing is not as much the part of guided or mental imagery. I think it's actually breathing itself is, on some level, maybe it's a distraction, but on the other, it's actually more focused attention. Because when you actually focus attention on the breath in and breath out, many things happen physiologically, but part of it is actually focusing instead of distracting. You are focusing on something, so you are actually getting yourself in a meditative state. And I think that there is more into it, and there is more and more research on why meditation works. Actually, simple meditation, meaning breathing meditation, when you just breathe in and out. Part is probably that it actually decreases the sympathetic discharge, that flight and fight response. When you breathe slowly in and out, it actually decreases the sympathetic nervous system output, and you become more parasympathetic. So you become more calm. the heart rate goes down, the blood pressure goes down, all the hormones kind of settle. So I think that's part of why the concentrating on breathing works. The problem with meditation types of work for pain is that it requires much more training. As Maggie explained us, her personal experience, the pain distracts you so much that it's hard then to either work on the computer or concentrate on this, concentrate on that, or it's even hard to meditate, right? Because you are distracted by pain. So the breathing techniques are helpful, but you cannot push them. You have to be very open-minded and gentle, meaning one breath. Fine. I take one deep breath in, one out, and not to be now sitting on the cushion for 20 minutes and think that I can meditate for 20 minutes when I'm in pain, because you are setting yourself up to a failure, right? And why is that? Because pain will intrude. It comes, it visits, it comes back, right? And if you are training your mind to push it away, it comes back with more vehemence. It becomes this unwelcome tiger. I am coming in, I'm pushing in, right? So the meditative techniques to manage pain are somewhat different. They are actually, those are some of the Eastern techniques, mainly from Buddhism, that they actually allow the pain to become part of your experience. So instead of pushing it away, you acknowledge it. So Maggie, if I can use you as an example, in your experience, the training in mindfulness-based pain reduction would be to acknowledge, okay, I'm living with EHE and I'm living with pain. So I'm not going to fight against you, because pain times resistance becomes suffering. Instead, I will say, okay, pain, here you are. Let's live together. Let's live together good enough that I can do my work, that I can concentrate on different tasks, and you are still part of my experience. I'm not going to fight you. I'm not going to use up my energy to fight you. I am going to allow you to cohabitate with me. That's a mindfulness approach to a pain, right? Now, there are very defined techniques in some of the Eastern Chinese and Tibetan and other traditions where, for instance, one that comes to my mind is pain becomes a concept of, it's a beautiful tiger, meaning it's there, it's part of me, it's a tiger, like it's not something that's the most welcoming pet like Connie's or Danny's cat. Yeah, it's a dangerous beast, but I'm welcoming you to part of my experience, so I'm taming you down. See, that conceptual framework is very different than our Western framework of pushing it away and switching it off, which Heidi is accomplishing, but Heidi is one of the highest achievers that I ever met in pain management. Most of us are good enough to cohabitate it, to live with it, to allow the tiger to be petted, to allow the tiger to walk with our journey, that it doesn't disturb us from our living until, I don't know, something happens, the tumor is removed, or the disease flare-up goes down, or whatever happens with the underlying condition that you are not totally in control of. Does that make sense, Maggie?
It definitely does. And it was really powerful what you said right there. If you could say it one more time, pain times resistance equals suffering.
Suffering.
Which is
So
very
there are people
Yeah.
who may not resist the pain, they are suffering less.
That's really interesting.
So so that's a concept of a chronic pain that's worthwhile to think about. And it's not that concept that the doctor is telling, you know, I'm sorry using Heidi, is telling this is not a real pain. You know, since your EHE is under control, you know, this is not pain. This is in your head, right? And I'm sure that many of you heard that. No. That's not what I'm saying. You know, but when you are resisting pain, it multiplies and you suffer more. So learning how to live with it, and perhaps letting the pain to go on vacation at times. That's okay, right? But it doesn't mean that you are pushing it all the time. So it becomes part of our experience, but it causes less suffering conceptually.
Yeah, it occurs to me that resisting and pushing make me feel exhausted.
Yes,
That which is why I think you feel more like you're suffering more.
that's right. That's right. That's right. So I know we have only a few more minutes. So what we explored today were, one, Abby, your Western concept or our Western concept of pain comes from periphery or visceral pain, comes through the nerves, comes up the spinal cord, comes to the brain, where on multiple levels it's being processed through different hormones, etc., and then eventually it creates an emotion. And what we worked on is on few ways of managing the pain or becoming more in power of our pain, which was distraction, guided imagery, some of the concept, very basic startup concept of finding a solution in a moment for pain, like Heidi's concept of pain switch on and off. And then we started to talk a little bit about, as provoked by Doug, around mindfulness and mindfulness-based reduction, pain management, which is a very powerful concept that's coming much more from a different culture, not a Western, but more Eastern culture, where people thought about how the mind actually manages the body and how to allow the mind to become more in charge of the body instead of body in charge of the mind. We have few minutes for questions. Reminds me of living in the current moment, what you can do now with how you are currently feeling or what level your pain is at. That's right. Lovely way of thinking about it. Instead of, I wish that I had no pain, right? That may be a wish that, you know, may not be a reality, but I wish I can now live with this level of pain, or can I get it down so I can live with it? If you are in a state of a condition where pain is part of your life or part of your disease, right? If we cannot get rid of it, can we allow us to live with it as good as it gets? And that doesn't mean to be defeated. That's not what I'm saying. It's actually being able to do something about it.
I think something Heidi touched on is important too, is that some of these concepts could be employed concurrently with prescription medicine, management, or other sort of Western, therapy
Yes.
for pain, would you say?
Absolutely, absolutely. And, you know, we have been working with Heidi to find a pharmacological approach. So, you know, non-pharmacological approach is just part of the approach. But, you know, with Heidi's permission, her wonderful PCP was lost, didn't know what to do, right? And is now welcoming this work that we have to kind of learn together with Heidi how to help her to manage her pain. So it's a team approach that brings all kind of modalities to the pain management. And I think that's the only way to live with a complex illness like EHE.
Dr. Vesel, I know we only have a few minutes, so if anyone has questions, but something we talked about before, which I think might be interesting, but if we don't have enough time, is the idea of pain versus the fear of pain. And I was wondering if you could talk about that a little bit. But also I know it's 3 minutes, so you can turn that down if that's way too much to dive into now.
Yeah, it may be too much to dive in, but I think it's an important concept. It's an important concept that when the pain becomes so threatening, it becomes very difficult to distinguish between what's pain and what is fear of pain. And I don't know, I see some of you nodding. That's something that me as a pain physician address with my patients, especially when there is a chronic pain and then acute pain comes like a surgery, right? For a patient with chronic condition like EHE. Then we talk a lot about, we use pain medications not for the fear, but for the pain. And that concept, when we acknowledge that together, becomes liberating, because sometimes we reach for medications because we are fearing, because we experience so much pain that we don't ever want to feel it again. So that may be a concept to contemplate about as well. You know, is this pain or is it the fear of it? Joni, the door. What are next steps to begin this process? Online resources. I will put it back to EHE Foundation. Very good question. And that's something that Abby and myself and EHE were starting to think about, to apply for a grant or to get somebody to help us to create some online resources, but we didn't get there yet.
If you know of anything that we could link to, whether it's something that you have at Tufts or anything, I'd be happy to put links on the community connections page where the recording of this will be posted. If we can come up with anything just to, I don't know if it's, you know, a website that has, you know, a good guided meditation or something like that, you know, we'd be happy to put something out there just to, you know, give you something.
Absolutely. And if there is an interest from EHE, you know, we would be happy to dive deeper into some of these concepts that I think are very helpful. I was trained in hypnosis by an incredible pain psychologist from Vancouver, Leora Kuttner, who wrote wonderful books on pain in children. So we can definitely look into some of the more advanced techniques for procedures like Connie was describing, which fascinated me when you said I was ice fishing. In fact, the concept of imagining cold causes vasoconstriction in the area of where they put the epidural. So it actually was helping with management of your pain, but you intuitively knew that without being trained to do it. So there is a lot more that we can explore in the future, and I'm happy about, you know, later, I can't overpromise, but happy to engage with EHE and find and develop some resources.
You've been so generous with our community. Just thank you so much. These are always, your sessions are always very powerful, and I feel like they allow people to admit, you know, that they're in pain, admit that they're maybe they were suffering, and now they've got, you know, hopefully ways to move into a more controlled relationship with pain. So, but we really appreciate your expertise on this, because I think it's something that is a current or an undercurrent in our community all the time. You know, someone is experiencing something like this. So that's wonderful. Does anyone else have any questions in the to put in the chat before we wrap up?
I just put at least the Leora Kuttner and Child in Pain. She wrote 2 books, which is interesting, and it's worthwhile because I think that we can learn a lot about pain from developmental point of view of children. And I'm happy then to, within maybe a couple of weeks, to, with Abby, collect some of the websites and literatures that are out there to be available for the EHE website.
Well,
It's an honor to meet all of you. Thank you so much for being so open to teach us and allow us to teach you as well what we know.